Hello and welcome to the wonderful world of sleep medicine and dental sleep medicine. My name is Dr. Michael Simmons. I'm a dentist, and I'm going to take you through a lot of the field that we're dealing with when we talk about sleep disorders, sleep disordered breathing. And I'm going to introduce a lot of other concepts to enable you to be able to screen and catch these patients in your office. And if you choose to treat them, I'm going to give you some background and confidence so that you can take on these cases. And of course you will be collaborating with physicians because there's a lot of medical consequences from sleep disordered breathing, and you don't want to be taking on this challenge by yourself. If you look at my background information, you'll see that I graduated in 1981, and since then I've got a lot of extra training, especially in the field of TMJ and orofacial pain and unusual disorders of the head and face, including sleep disorders. And it's my goal to enable you to understand the difference between what we may be doing in dentistry right now and what we hope to be able to do in the future. And while it is true that as dentists we tend to treat and fix and correct certainly some dental disease, we have to put on a different hat when we're talking about sleep disorders, because we don't actually fix anything in those circumstances, rather we manage it. So it's a different viewpoint. It's not the dental surgeon or orthopedic surgical approach, but rather it's more of a medical management approach. Now, as you can see from the screen, also I'm known affectionately as the Soap Man at UCLA, where I've been teaching for the last 20 years. And that's because I teach SOAP notes. SOAP notes relate to subjective, objective assessment and procedure and plan notes. And those are medical type notes which I would encourage you to learn how to use and to actually utilize when you're treating sleep disorders. Anyway, as we go down this journey, I want to first introduce you to the different components of sleep medicine and be able to help you understand why it's so important that you take these things into consideration in part of your everyday practice. So first of all, I want to engage you in what the problem is, sort of a Sleep 101 introductory course. I want to also show you what the connection is to dentistry, why dentists should be involved, and why I think we're going to end up being one of the major players in catching these disorders early on. The real question comes down to, should dentists treat these conditions? And if so, what part of these conditions should we be responsible for? And if we look at some of the literature on how our education compares to physician education, you'll see that there isn't that much difference, that there really isn't that much time spent by physicians in their MD training program, at least up and through the end of the 1990s, in sleep medicine. And certainly some dentists got more training, some got less. As an example, in 2008, we taught at UCLA dental students about 7 hours in sleep medicine. And that would put them way ahead of most physicians getting their MD degree. And last, and certainly not least, I want to touch upon why dentists should be involved and why now is the right time. So fasten your seatbelts and we're going to go through and see if I can encourage you and enable you in this process of learning. Just as a background and to get you up to speed, I'm going to cover the last few thousand years worth of history in sleep and the field of sleep medicine. Originally, sleep was thought to be an uneventful state. Basically, nothing was happening. The patient was shut down and was in almost a hibernation state. And it was believed that there was a cooling of the blood, and certainly if you measure the temperature of people asleep, you might notice that there was indeed a temperature change, usually up to 2 degrees during sleep. But it was this concept of cooling of the blood that really explained what was going on during those 8 hours at night. It was only around the 1950s that the medical components started to become interested in what was going on during sleep. One of the founders or fathers of sleep medicine is Nathaniel Kleitman, and he started work in studying sleep in the 1930s, and he had emigrated from Russia. And he read 6 languages and was able to cover the research that was going on in many different countries. And so he developed some interesting insights. It turned out in the 1950s that he started to do evaluations of people during sleep, watching eye movements. Now, there were many different eye movements that were going on, but in particular there was this rapid eye movement, and that was something that drew attention. There's a slow eye movement that people have noticed for a long time, but it was the rapid eye movement that they were able to measure, and often measure with probes that could be stuck at the side of the face. And Kleitman worked along with a graduate student, Asarinsky, and they noticed and collected data on rapid eye movement and found that there was a close association between the rapid eye movement and dream state. Now, while a lot of dreaming goes on during rapid eye movement, and when you woke up these subjects during the bouts of rapid eye movement, there were clearly vivid dreams that could be explained and spelled out. We also do dream in other times during sleep. It's not completely reserved to REM sleep. But the only other interest up until the 1950s, and REM was discovered around 1953. The only other really interesting concepts that the physicians focused on was narcolepsy, an African sleeping sickness, and encephalitis lethargica. Now, between 1916 and 1930, this encephalitis lethargica killed about 5 million people. And the people would die because they were either excessively sleepy and they would go into a coma, or they had insomnia. And if they were unable to sleep for days and weeks on end, they would eventually become agitated, cognitively impaired, unable to function, and also finally lapse into a coma and then death. So we don't know exactly what happened between those years and why it had such an enormous impact, but it was probably a prion disease. Now, African sleeping sickness was also interesting to people because it was a disease that was transmitted by a tick, and so that had some merit in an infectious kind of process. So REM sleep, discovered in 1953, was the major turning point of medicine, and all of a sudden there was enormous interest in what was going on during that time of sleep. Up until then, that 1/3 of our lives was largely ignored as being fairly dormant and uninteresting. The first interest in the United States in sleep-disordered breathing as a national interest was around 1970s, and it was in 1975 that the American Academy of Sleep Medicine, the precursor to that, actually started to become a known entity. Now, to give you a sense of illness in the United States and how sleep-disordered breathing fits into this, and sleep medicine fits into it, I want to give you some major overview. And when we look at items such as asthma, we have about 10 million people that are affected. When we look at diabetes, 15 million are affected, and that's according to the CDC in 2004, and that number is increasing. Obstructive sleep apnea affects more than 12 million people, and we're talking about obstructive sleep apnea syndrome, where they don't just have the disrupted sleep patterns, but they also have the daytime sleepiness that's associated with such disrupted sleep. But if we were to look at chronic sleep disorders, we would see that it's a bigger picture of maybe 40 million people, and that includes people that just have upper airway resistance, they're snoring, they don't get restful sleep. And if we were to look at sleep problems as a group, the whole group, which includes insomnia and other issues, we're hitting between 50 and 70 million people in the United States. And if you consider there's about 300 million there, that's a pretty significant chunk of people to be affected. Sleep disorders at present are not receiving adequate attention. About 95% of the people that have problems go largely undiagnosed, and mainly that's because health professionals haven't had adequate training. And as you'll see later, you'll find that most medical training up through 1980 was less than an hour through the whole 4 years of medical school, MD training. So the National Commission on Sleep Disorders Research posted a comment that there is an urgent need for physicians, dentists, all healthcare professionals to be able to identify and refer or treat patients with sleep disorders. So this is a very large problem, and right now it's not being addressed significantly. In the United States, sleep deprivation, and that's where we're not getting an adequate number of sleep hours per night, affects more than 30% of the population. During the week, people get less than 7 hours, and on weekends they try to make up. Unfortunately, when you're sleep deprived for days upon end, you cannot just make it up in one night. About 7 out of 10 adults admit to frequent sleep problems, although most of them are not diagnosed. And that came from a poll put on by the National Sleep Foundation, and that was evidence that was collected in a poll in 2001. Sleep deprivation and sleep disorders are estimated to cost Americans over $100 billion annually in lost productivity, medical expenses, sick leave, property and environmental damage, and also there's a dramatic effect with medical costs associated with the complications that we're just beginning to unravel at this time. If you consider that about 40% of adults in America snore, and that's in the age group over 40, we are considering 87 million Americans snoring, and about 45 million of those snore every night. We have studies, large cohort studies that show about 9% of men and 4% of women having signs of obstructive sleep apnea on testing. And 4% of men and 2% of women have signs and symptoms of obstructive sleep apnea. So the signs may be somebody snoring, gasping, having momentary pauses in their sleep, but the symptoms would include daytime fatigue, feeling unrested, not being able to cognitively function at the level that they would like to function at. Untreated obstructive sleep apnea alone is thought to cause $3.4 billion in additional medical costs. So this is on top of all the accidents and injuries and other costs associated with sleep apnea, including the inefficiencies of work that patients have because they're not able to function cognitively. There was a large study done, and it was funded by NIH, to investigate sleep deprivation. And it was a landmark study, and it was published in 2006. And the highlights of it were that 50 to 70 million Americans suffer from chronic sleep disorders. And excessive daytime sleepiness alone is $150 billion annually in this lost productivity mishaps, and another $48 billion per year in the medical costs related to motor vehicle accidents that involve drowsy drivers. 20% of all serious car crashes are associated with excessive daytime somnolence, and that's independent of the alcohol problem, and that again is an enormous problem. And because unfortunately the large majority of this problem is not addressed, we need to make a major difference in society to have any sort of impact. So if we describe what the differences are between the medical approach and the dental approach, we could look at it in a simplistic way. Sleep medicine is involved with diagnosis and management of sleep disorders that includes not just sleep disordered breathing, such as snoring to obstructive sleep apnea, but also insomnia, circadian rhythm disorders, narcolepsy, movement disorders, even bruxism. Dental sleep medicine is a component of that because we're involved primarily with the treatment of sleep-disordered breathing. We use oral appliance therapy. We can address things with upper airway surgery like a mandibular or maxillary advancement. And we also can address it with orthodontic arch development. So primarily we're dealing with a small component, well, not entirely small, but maybe 1/3 of sleep disorders. And if we consider bruxism as a movement disorder or a parasomnia, we may be dealing with a few more percentages of the total problem. To give you a sense of how the dentist fits in, we should look at a few statistics. First of all, the American Academy of Dental Sleep Medicine is the premier group of dental practitioners that are interested in sleep medicine. There's about 1,200 to 1,300 members now, and these members do put more time and effort into incorporating sleep disorders into their practice. Of course, there are a lot of other groups that deal with this. We could consider the American Academy of Orofacial Pain and other facial pain academies, and they also have a lot of people that are interested and contribute to the field. In comparison, there's about 6,700 sleep physicians that are members of the American Academy of Sleep Medicine. So they have a larger pool of practitioners, and they're dealing with more problems. The number of accredited sleep centers where sleep studies can be done is just 1,169, or in that area at this time. And if you look at the total number of sleep centers, obviously there's a majority that are unaccredited, you're hitting about 6,000 sleep centers in the United States. Now, obviously, this is not going to handle the number of patients with sleep disorders that we have, because we're talking in the range of 30 to 40 million people, and just 6,000 sleep centers is not going to cut it. If we were to look at the number of specialists that are expert in sleep medicine, we would look at a group primarily made up of pulmonologists, neurologists, ENT or otolaryngologists, and perhaps we would have some internists and primary care physicians as well. If we looked at that total, we're not talking about that many sleep experts in the United States. We've got the potential for perhaps 28 to 30,000 sleep experts. But at this point, that still does not give us nearly enough manpower to be able to address these problems. To give you a comparison, there are about 175 to 180,000 dentists in the United States. So if we were to get every dentist involved and interested in screening for these disorders, we could make a huge impact. Obviously, not everybody would be interested in treating it, but perhaps 10 or 20% of our dental population would have some interest and would be able to collaborate and work to help solve this problem. So demographically, we've got a significant issue. But let me take another step back and go, why is this even a problem? Why is sleep such an important part of our lives? And the basic concepts with sleep are, first of all, it's restorative. People that do not sleep do not function well, and if you are deprived of sleep long enough, you will surely die. We need to have restorative time after rigorous activity, after expending our time. We need downtime. During sleep, we also get release of growth hormone. So if you want your child to grow, to be as tall as possible, you want to make sure they need and get the sleep that they require. And whereas an adult may need 7 to 7.5 hours per night, children often need 10. And if they're infants, it's almost a half of their half of their hour, their 24-hour period is spent in sleep. The other thing that's interesting about sleep is it helps integrate learning. I remember watching a recent 60 Minutes expose on sleep, where they found that testing people with mathematical or number memory testing, these subjects did much better if they were allowed to sleep after they first learned the number sequence. Sleep helps to integrate our memories, so it organizes them and allows us to recall them at a better rate. So pulling those all-nighters to try to get through an exam may not be the best way for you to perform on those tests. The other thing that's interesting about sleep is it helps regain balance of our automatic system, our autonomic system, our homeostasis. For instance, temperature regulation is very important, and it is enhanced by sleep. In fact, there were some studies done with rats that were put in a long tube with a temperature gradient, and they sleep deprived these rats. And during the time that they were sleep deprived, the rats would move from the colder temperature to the warmer temperature on that gradient in the tube. And eventually, as they were sleep deprived more and more, they would actually move into areas of the tube where they would cause tissue burning damage.